We're going to be talking about body mechanics and moving and transferring the patient safely. One of the reasons it's so important to make sure that we're moving our patients as safely as possible, because safety is a basic need. We've talked about Maslow's hierarchy of needs, where we've talked about the physiological needs, food, water, shelter. We have to have those to live. But the next rung of that pyramid is safety. And we want to make sure that we keep our patients as mobile as we can, as independent as we can, but try to decrease the risk of injury. Now, no matter how careful we are not always going to be able to keep them from falling. The accidents still can happen, but we will try to reduce that as much as possible. The term body mechanics means using our body in an efficient and careful way. It means using good posture, using a good wide base of support. We want to try to prevent workplace injuries. Back and neck injuries are one of the most common healthcare injuries that you're going to see. I've had many friends, unfortunately, over the years who have gone out with neck injuries, with back injuries, and never been able to work again. Plus, their quality of life has become decreased because of it. And you want to keep that from happening. So some basic rules of body mechanics so we can keep ourselves safe is plan your lift. You want to make sure that you're asking for help if you need it, that you have a good idea of how much that patient weighs and what their mobility level is. And that first time that you move that patient, don't even hesitate to get extra help. I mean, you should be asking for help anytime you think you need it. But if the first time you're going to move someone and you don't really know what to expect, get help. Make sure that you have, just that extra buffer so you won't get hurt in the process. Get a firm footing and bend your knees. You want to make sure that you're tightening your stomach muscles, always engaging your core, and lifting with your legs, not with your back. You don't want to do things with your back because those bones are just so tiny and so individual. You don't want to put a lot of pressure on them. So if we keep our back straight and we lift with our legs and we tighten our stomach muscles, we'll be able to balance our body a little bit better so we can move more efficiently and more effectively without getting hurt. Now, the other thing that's important is keeping the load close. So I know we've talked about infection control issues where we say don't bring things up against your uniform. And at the same time, I'm telling you when you're moving a patient, it's better to keep things closer to you. So we do want to carry things and move things closer to our body, but not up against our uniform where they can become contaminated, where things can become contaminated. We want to make sure we're not bending at the waist when we're picking items up. You can see here when you're bending at the waist, you stretch those tiny little ligaments and those bones and those discs right there. You put a lot more pressure on it than distributing that pressure over your large muscles of your legs. So we use our legs when we pick up items. We want to make sure that we're bending down, we're squatting down, we're picking up the item. Again, try to hold it closer to you, but you do want to keep it away from your uniform as much as you can. What we're trying to prevent here is work-related injuries, and we're trying to prevent injuries to the patient as well, but we also want to keep ourselves safe. Musculoskeletal disorders are very, very common in nursing. As I've already mentioned, back and neck injuries are very common, and nursing assistants are at the greatest risk of this happening because you're doing most of the transfer, the lifting, the making beds. So if you don't learn how to use good body mechanics from the beginning and incorporate that into your practice of nursing, you're going to have a short nursing career. So when we're moving and positioning the person, one of the reasons it's so important to make sure that we are moving them and repositioning them frequently is because it makes breathing better. A person can breathe better if they're sitting up in their chair better, if they're sitting up in bed and they're not slumped down using, with poor posture. So it does make the lungs be able to expand more fully and take in fuller, deep breaths. Circulation is also promoted. The more we move someone, the more their muscles move, the more their circulation gets going, and it promotes more blood flow and oxygen to the body. Moving a person is important to prevent pressure ulcers. And pressure ulcers are also known as bed sores, where the skin breaks down just because there's so much pressure in one spot, where you have a bony prominence pushing against the skin, and the skin and the tissues are getting trapped between that bony prominence and then the bed or their chair that they're in, and it wears the tissue down, and that's very dangerous for a person. They can get infected, they can end up having an infection that goes through their entire blood system and potentially even die from them. Contractures is an abnormal shortening of the muscles, and the typical place we tend to see it is in the hands, where the hands kind of contract right down and you can't even open them back up. Sometimes you'll see it in the legs of patients if they're not moving or walking. It also helps promote urinary and bowel function. It helps peristalsis keep going so they don't get as constipated. And it also just promotes comfort and a sense of well-being to get moved and repositioned. The one thing that you must learn, that you must ingrain in your nursing practice, is when someone cannot reposition themselves, you are to reposition them at least every 2 hours, more if you think they need it. So this is an example of what a pressure ulcer looks like. And again, pressure ulcers can occur from lying or sitting in one place too long. Wet, soiled, and wrinkled linens can also cause it. And laying on tubes, laying on tubes can cause this as well. We will talk in a later class about tubes. And one thing that I'm always going to stress with tubes, urinary tubes, feeding tubes, oxygen tubing, you need to make sure that you're aware of where the tubing is. When you reposition a person, you make sure they're not laying on any tubing, because that constant pressure of the tubing digging into their skin can cause these pressure ulcerations as well. And as you can see here from this is very easily can become infected, and then that infection can get into the bloodstream and can get carried throughout the entire body. These are common areas where we see pressure ulcers, and the most common is right here on the sacrum. So right here on the buttocks, this is one of the most common places you're going to see pressure ulcers. Another really common place we see for someone who's bedridden is right here on the heels. Now, if the person's wearing oxygen, we tend to see them behind the ears or right over the ears. Other places I've seen them, if you have a patient who sits in a wheelchair all day and you don't move them around in that wheelchair, right here on the ischium is another place that you're going to see it. Contractures, that lack of joint mobility caused by that abnormal shortening of a muscle. Again, it's caused from not moving enough. And so we have a responsibility to our residents and our patients when we're taking care of them, that if they can't move, we move their body parts for them. So if you have someone who's bedridden, we need to move their arms and their legs. If we have someone who's maybe disabled on one side of the body because of a stroke, we would need to move that one side of the body. So whatever part of the body that they can't move, that's what we need to be moving for them. Now, before you reposition someone, always, of course, as with anything, any function or any task that we do for our patients or residents, is we wash our hands. You always wash your hands with soap and water, or at least hand sanitize. Knock and introduce yourself. Now, hopefully we already know our residents, so we've already introduced ourselves and we found out what they wanted to be called, but we're going to knock every time we go into that door. Identify the resident or patient, and again, we identify someone by looking at their ID band, or we can identify someone by asking them their first and last name and even date of birth. You don't want to just say, "Are you Mrs. Jones?" because anybody can answer yes to that, and many residents who have dementia do answer yes to that. Make sure you know what they're allowed to do. Now, this frequently happens. You can ask a resident, "Oh, can you get up? Can you stand up?" And they'll say yes, but they can't. And a perfect example I can give you is I had a student one time who asked me to come in and help her move the resident. I asked her, I said, "Did you check? Can they move? Are they allowed to get up? You know, is it okay for 2 people to do it?" She says, "Yes." She goes, I asked, and they said that they could move. So I assumption on my part, that she had asked the regular CNA, looked in the chart like she was supposed to. So we go to get the resident up, and this patient is just dead weight. She can't support any weight on her legs. So we put her right back in bed. I go get the regular staff, and I said, we were told she could get up, and the regular CNA said, "Well, who told you that? She needs a lift." Well, the resident had told her that. my student had asked the resident, can you get up? Can you bear weight? And the resident said yes, so she assumed that that was okay. And many of these residents are confused and they don't really know what they can and can't do. So make sure we need to check with the chart. We need to check with the regular staff. And it's also one of the reasons why we have a policy for the college that if you're getting a person up, you have your instructor with you or you have the regular staff with you. We always want to make sure we provide privacy, be as gentle as we can, use our good body mechanics, engaging our legs, engaging our core muscles, not just you bending with our back. Be smart, get help when we need it. Now, you aren't always going to have help. When you become a CNA, when you get certified, you'll be able to do some of these transfers on your own if the patient's able to. But for our policy at the school, you will have help. Use pillows to help position someone correctly. And again, pay attention to your tubing. Know where it's at before you start moving that person. And after we position a person, we provide for comfort. Always make sure the call light's in reach. Lower that bed back down in a low position. Leave the room neat. Wash our hands. Do a complete safety check of the room. Is the bed in low position? If they use their rails, are the upper rails up? Is their call light in reach? Document how they did, and if there's anything abnormal that we found when we were turning or repositioning them, always make sure we let the nurse know. Now, some of the positions, and you do need to learn your positions, semi-Fowlers is about 30 degrees with the head of the bed up. Fowlers is usually 45 to 60 degrees, and this is usually will promote breathing a little bit easier when that head of the bed is up. And you're going to find that some of the newer beds, the feet will notch up too. When you raise the head of the bed, the feet notch up just to keep the person from sliding down in bed. So you have to put the head of the bed up, and then if you want the feet, then you have to put the feet back down. And that's the newer beds tend to do that. High Fowlers, which is 75 to 90 degrees. And if you're feeding someone, we are going to recommend the 90 degrees. Sit them all the way up. That is a more natural position for eating. Supine position, laying flat, okay, just laying flat on their back. Prone position is laying on their stomach, and the head, of course, will be turned to the side. Now, I will say a lot of your elderly patients are not going to do well rolling over onto their stomach, but we are finding that it does actually help with lung tissue function. And so we're finding that patients that are on ventilators, like in hospitals in the intensive care unit, our COVID-19 patients, that they are flipping them over onto their stomach even while they're on the ventilator, that it is actually promoting better lung perfusion. Lateral position is a sideline position, and in the sideline position, you're going to have a pillow under the head, a pillow behind their back. It doesn't go under their butt, it goes under their back, pillow underneath this arm, and a pillow under the legs that goes usually from knee to ankle. The top leg is going to be flexed a little bit, and then you just have them kind of tilt back on that back pillow. And then Sims position is where they start off on their side, but then you flex this top leg so sharply that it kind of puts them in a half sideline, half prone position. And Sims position is a really good position if you have any like rectal exams, suppositories, enemas, anything like that that needs to be done. This is a probably more common position for that. Trendelenburg is a position that we, as a CNA, we are not going to put our patients in. Trendelenburg, the nurse will do. And what Trendelenburg does is it raises the entire bed up and then it tilts it. It actually tilts the whole entire bed so the feet are higher than the head. Now, this can be potentially dangerous to have that for a long extended period of time, which is why as a CNA we don't usually put our residents in Trendelenburg position. The nursing would do it, but this is a position that they use for patients that are going into shock, that their systems are starting to shut down. Will help bring the blood pressure up. Reverse Trendelenburg is where they put them kind of like on a tilt table and stand them up, and there are certain tests and procedures that they do in this position. Now, when we're assisting someone up in bed, this is a draw sheet underneath them. And a draw sheet, you can actually use a regular top sheet, fold it in half, and put that under them as a draw sheet. Draw sheets go from shoulder to mid-thigh because the biggest bulk of their weight is right here in the torso. So you want that draw sheet to go from shoulder to mid-thigh. You have two people, one on each side, and you roll the sheet up as close to the person as you can. And then on the count of three, one of them is going to say, okay, on the count of three, we're going to go up. Now, if your patient can bend their knees and help push up with their knees, it makes it even easier. And one thing that's really recommended is to put a pillow up here by the headboard. So if you do get if you've had your Wheaties and you have this really strong push on the way up, you don't knock their head into the headboard, because I've seen that done. Actually, I've done that, unfortunately. We want to protect the skin when we're moving a patient. The term friction and shearing. Friction is rubbing of a body surface against another. So when we wash our hands, we're using friction. This is friction, okay? We're rubbing our hands together to clean them. But when you have elderly people and the skin starts rubbing together one surface against another, it can tear open the skin and cause pressure ulcers. Shearing is when the skin sticks to the surface while the muscles slide in one direction. So the body is, you're trying to push the patient up, but yet their skin is stuck on the bed, and so the skin stays down here, but you're dragging them up here, and the skin literally just shears open. When we're moving someone up in bed, some of our residents can actually have good upper body strength. So for instance, we have a gentleman over at one of the facilities we go to. He does not have lower body strength, but his upper body is very strong, and so he will have a trapeze bar. So this trapeze bar hangs over their bed, and he can grab onto it, and then you would help lift the lower body while he's kind of pulling up with his upper body. Now, if you're going to roll someone on their side, one thing that we like to do first is bring them over to the side of the bed. If your patient's in the middle of the bed and you roll them on their side, by the time they roll over to their side, their face is going to kind of face plant into the side rail. So when you roll someone to the side, first you want to bring the body over. So if they can't help you do that, you can bring the upper body over, then the middle part of the body, and then the legs. So they're starting off in this position. So then when you roll them on their side, they're going to end up in the middle of that bed. Now the term dangling means it's sitting on the side of the bed where they're just kind of sitting there and just kind of adjusting. So you sit the patient up, and then you bring their legs over, and you just kind of let them just sit here on the edge of the bed. They're not ready to stand up yet. They're not ready to get transferred over to that chair. They're just kind of adjusting to getting up into a sitting position. A lot of residents, a lot of your elderly population, when you stand them up too quickly, they have what we call orthostatic hypotension, and that is a drop in blood pressure. Normally, if you stand up really quickly, the valves in your legs will shut, and so it'll keep the blood kind of distributed through your body so it just doesn't drop down to your lower legs. But your elderly population, the valves don't shut quite as quickly, so when you stand a person up really fast, the blood drops down into their lower legs, and then they feel lightheaded and they can pass out. So by letting them dangle there for a little bit, it kind of lets their body start adjusting to that sitting position, lets the valves start to close off a little bit better before you stand them. So we'll talk about orthostatic hypotension a little bit more, but it's actually when you go from a lying position to a standing position and the blood pressure drops too low, and then they get dizzy and lightheaded. You might have felt this yourself if you've ever had the flu, like a stomach flu, where you've gotten dehydrated. You've gotten out of bed real quickly and the whole room starts spinning. That's probably from orthostatic hypotension. A chair position, when you're putting someone in a chair or transferring them over into a chair, you always make sure their feet are flat on the floor. Always make sure they have non-skid footwear on, that the back is nice and straight and against the chair. And don't forget, if you're leaving someone sitting up in a chair for long periods of time, they still need to be readjusted. You can take a small towel and kind of tuck it under one side of their bottom, and then an hour later tuck it into the other side of the bottom. But just because you got them up to a chair doesn't mean they don't still need to keep moving. As far as wheelchair safety goes, When you're transferring someone over into a wheelchair, the wheels are locked when you're transferring them over. So you always make sure the bed's locked when you're getting ready to move someone. You make sure their feet are flat on the floor, that they've got non-skid shoes on. When you're moving someone over to the bed, if they're a fall risk, we always use a gait belt for safety. And we're going to do on the count of 3, and you have them push up from their hands. You don't have them grab onto your neck, not ever. That is a huge safety issue. The wheelchair wheels need to be locked when we transfer them over, but then once we get them in the chair, we might want to make sure the wheels are not locked, because you want them to be able to move around in their room. If you keep them sitting in their wheelchair, but you keep the wheelchair locked and they can't move themselves, then it's actually considered a restraint. And again, if you're going to sit them in that wheelchair, we need to reposition them every 1 to 2 hours. As far as using a gait belt, Gait, G-A-I-T, is an ambulation belt or a transfer belt. If any patient is a fall risk, you should be using a gait belt. And I really don't like, you see here where you see him hugging his waist. I always try to ask the person to push up from the armrests of the chair. I don't like to let a person grab onto my body, because if they start to fall, it's instinctive to save yourself. If you let them put their hands up here around their neck, they're going to grab your neck and pull your neck. If they're small, you probably would be okay if they grabbed your waist, but if they're a large person, they can actually pull you over. So you want to make sure when you use a gait belt, gait belts are always snug. They're nice and snug, but you should be able to get a few fingers underneath them. The belt, the buckle itself, should never be over the spine. It should be in the front. Gait belts always go over clothing, and you always hold the gait belt underneath. You hold it this way, where you're gripping onto the belt this way, not this way, because if it's this way and they start to fall, the belt will just slip right down. So you come underneath the belt. Pivot transfers, if you have someone with a weak side, so if a person has a weak right leg, they're going to pivot with their left leg. So that wheelchair is going to go on their left side. So you're going to pivot them to their left side. If they don't have a weak side, then you can actually stand a person up, have them take a couple steps and sit down over into the wheelchair. If they have a weak side, you want to make sure that strong side is the side that's pivoting. And as far as using mechanical lifts, there is a sit-to-stand lift. A sit-to-stand lift is for someone who can bear weight on their legs. They need help. They're not super steady on their legs. They maybe have difficulty walking, but they can bear weight on their legs. We can do a sit-to-stand lift. This one right here, this is a Hoyer lift, and this is for someone who's dead weight, who cannot bear any weight on their legs. And this is a mechanical lift that can actually lift them up out of bed and lift them all the way over and into their wheelchair, or from the wheelchair to the bathroom, or wherever it is you need to move them to. So mechanical lifts, especially the Hoyer lifts, it's ideal to have a second person with you if you can. You always need to pay attention on the lifts, that you're paying attention to the weight limits. There are weight limits on these. And so if you have a really large person especially, you need to make sure you're meeting your weight criteria. If you try to lift someone who's too heavy for the machinery, obviously it's a potential for an injury. And I think that's it with that. As far as ambulating with assistive devices, as far as why do we need to ambulate our patients, we already talked about. They need to keep moving. It prevents deconditioning. It makes them feel better. It gives them a better sense of well-being. It promotes circulation. It lets them breathe better. It promotes their digestive system. Ambulation is important, but we need to make sure they have non-skid footwear, either non-skid socks or non-skid shoes, so their feet just don't slip out from underneath them. You have just a regular pair of socks on them, those feet are just going to slide out. And as far as the purpose of dangling, we already mentioned, it lets them adjust to that drop in blood pressure sometimes that they have, or that drop in blood flow from their head, so they don't get dizzy. Now this gait belt here, you see how they're holding it from the underneath side. Other assistive devices, this is a walker. And walker, there are 4-point walkers, which is what this one is, or there's front-wheeled walkers where there's front wheels. There's wheels up here on the front legs. The front-wheeled walkers, a person could have a more natural gait with. The 4-point walkers actually have to pick up and walk into it. It's generally physical therapy who will determine what type of walker that they need. And then a cane There's 4-point canes and then there's single-point canes. The 4-point canes obviously are a little bit more sturdy. And again, physical therapy is usually the one who will evaluate them and determine what is best for them. But canes go on their strong side. So if you're walking a patient, cane goes on the strong side, you go on the weak side when you're walking someone. And if a patient does start to collapse, okay, I know I told you we don't bring anything up against your uniforms if we can help it, but this is going to be an exception. So if you're walking your patient and they start to fall, we don't want you to catch them and hurt your back in the process. We want you to do a slow, controlled fall for them. So if you're holding onto that gait belt, and normally when we walk a person, we're walking just to the side, slightly behind. So just to the side, slightly behind. You don't walk directly behind them because then your feet can kick into theirs and you can trip them up. So I'm walking just beside them, almost where their shoulder's right here and my shoulder's right here. So it's almost like my shoulder's just right next to theirs, and I'm walking them and they start to collapse. I am actually going to take the gait belt and just bring them into my body and just let them slide right down my body. So we'll ease the patient slowly to the floor, and what that's going to do is, even though that's going to be considered a fall, and anytime there's a fall, you stay with your resident until the nurse comes and checks them. So the nurse will come check them, physical therapy usually comes and checks them, and then they'll get the person up if they're sure that there's no injuries. Yes, we have to notify the doctor, we have to notify the family, we have to do vital signs. There's a lot of stuff we have to do, but if you control that fall, you're going to keep them from hitting their head, breaking their hip. They shouldn't get hurt with it. So even though they've hit the ground, if it's nice and controlled, they shouldn't get hurt with it. Call for help, of course, and of course we're going to have to document what happened as well. So that's going to end this session.